Hello, everyone. Our topic today is complex regional pain syndrome. These are the objectives of the presentation. Incidence. Complex regional pain syndrome is not a common disease. And part of it is because it's underdiagnosed. The incidence rate is 26.2 per 100,000 person years. Females are more affected than males. And also, it affects the upper limbs more than it affects the lower limbs. And this might have something to do with the arms are more utilized on daily basis more than the lower extremities. I'm not sure why, but I'm just speculating. Okay, so complex regional pain syndrome is basically a neuropathic pain. We discussed so many times before what is meant by total pain. A total pain is a sum of physical and non-physical types of pain. And this was coined by Dr. Cicely Saunders in the 70s of last century here. I'm going to focus on neuropathic pain because that's our main component. However, this doesn't mean that there's sometimes inflammation and sometimes nociceptive pain like myofascial pain disorder involved with the actual pain. But the predominant pain in CRPS is neuropathic. Also, non-physical component is always present, such as the emotional, social, and even spiritual. So what is neuropathic pain? Neuropathic pain is a pain caused by a lesion or a disease of the somatosensory nervous system. And basically, there are two types. There is the peripheral neuropathic pain and the central neuropathic pain. And in CRPS, in fact, you have both. Periphery starts at the periphery and ends in the central nervous system. And that's why the treatment is difficult. And you have to utilize different techniques. Features of neuropathic pain are stabbing, pins and needles, electric shock like numb, shooting, throbbing, burning, and so forth. And neuropathic pain syndromes are either positive symptoms on signs or negative symptoms on signs. And you can see all of this in a complex regional pain syndrome. If we look at the history, it started with Dr. Weir Mitchell, an American civilian war physician who described the condition in 1864, consisting of burning, hyposthesia, atrophic changes following nerve injury, and he named it causalgia. Causalgia from algia from pain comes from being caustic, being burning. Later on in the 1920s, Dr. René Lorich, he's a French surgeon, established a link between sympathetic nervous system and causalgia by demonstrating that sympathetic blockade or sympathectomy relieved the symptoms of many patients. Later on, Dr. Evans developed the term reflex sympathetic dystrophy. So now we have two terms, RSD or reflex sympathetic dystrophy and causalgia. And basically, the differentiation is reflex empathetic dystrophy is a trauma anywhere in the body, but causalgia is a specific nerve injury. Later on, this was changed to complex regional pain syndrome, 1 and 2. 1 being the RSD, and 2 is the causalgia. Then we have also two types of pain that we have to make sure which one is present because it will delineate the type of therapy we're giving to the patient. And this is sympathetically mediated or sympathetically independent pain. And in 2003, they came out with Budapest criteria for complex regional pain syndrome. And this is basically Budapest criteria. And since then, it's been, reviewed by many authorities, especially the IASP. We're going to go through all of this later on. I'm just showing you the original Budapest criteria. Okay, so complex regional pain syndrome. In 95, the International Association of Study of Pain introduced the CRPS 1 and 2. Okay, and they said these are neuropathic pain syndromes, and they try to avoid labeling it with the sympathetic system because some of these CRPSs, they are not related to the sympathetic system. So not all the pain in CRPS related to the sympathetic. That's actually create more complexity into the syndrome. So after they divided it to 1 and 2, again, they also divided the CRPS into sympathetically mediated pain and sympathetically independent pain. Centrally, there's changes in the morphology of the spinal dorsal horn, ipsilateral to the peripheral nerve injury, may be secondary to intrinsic mechanisms arising in a response to chronic barrage of impulses, or in response to retrograde transport of chemical factors from the area of the lesion. Increased spontaneous activity in the primary afferent neuron may be a factor leading to spinal cord glutamate release. The activated peripheral nociceptors transmit messages to the spinal cord through lightly myelinated A delta and unmyelinated C fibers, and this process leads to release of excitatory amino acids like glutamate and asparagine. The excitatory amino acids act on the NMDA receptors, the N-methyl D-aspartic acid receptors, causing the release of substance P, which subsequently lowers the threshold for synthetic excitability in normally silent second-order spinal synapses. The role of glutamate release in the spinal cord after peripheral nerve injury is being evaluated with growing interest. In addition, the functional changes, there is suggestion that the brains of patients with CRPS could have structural changes consisting of decreased thickness of the gray matter in areas related to the pons, or decreased thickness in the prefrontal cortices, or enlargement of the choroid plexus. The observation that some patients appear to have hemi-neglect further support also the involvement of cortex and the pathogenesis of CRPS. To wrap this up, peripheral nerve injury leads to increased barrage of impulses to the dorsal horn with the release of excitatory amino acids such as the glutamate, and this will eventually release substance P that mediates the excitability of these cells. Now, this is at the peripheral level, and this, also we have a central level where there's microglial activation. Microglial cells are macrophages in your brain, okay, and these are responsible for, engulfing all these excitatory amino acids that's unnecessary in your brain, the glutamate. So if you're having a process like central sensitization, the inability of the microglial cells to capture this glutamate is inhibited. And in fact, the microglial cells release the glutamate, and this will lead to central sensitization in your brain. And as you know, NMDA is involved in so many diseases in your body, including neuroinflammation, decreased attention span, chronic fatigue, depression, sympathetic nervous system overstimulation, intellectual decline, drug-seeking behavior, and centralized pain, and insomnia, of course, and memory loss. Remember, we give nowadays memantine, which is an NMDA antagonist for patients with memory loss and dementia. RSD or causalgia. There's no way that you can differentiate between the two problems except with the history. Anyway, if it's localized to a peripheral nerve, this is CRPS type 2 or causalgia, and if it's not, it's type 1 or RSD. Whether it's sympathetically mediated or not, you have to do sympatholytic blocks to differentiate between the two. But anyway, the features are, as you see, dysautonomic changes, dystrophic changes, disproportionate pain, and diagnosis of exclusion. I call them the 4Ds. Again, the initial signs and symptoms may begin at the time of injury or delayed for weeks. Sometimes the traumatic event cannot be identified. CRPS type 1 occurs without evidence of major nerve damage, whereas CRPS 2 consists of the same signs and symptoms following an identifiable major nerve lesion. Because CRPS 1 and 2 have identical diagnostic criteria, it seems likely that the cause of CRPS 1 is also a nerve injury. But the nerve injuries go undetected because they are partial fascicular or involve primarily smaller unmyelinated axons. These specific types of nerve lesions are notoriously difficult to diagnose by examination or by electrodiagnostic studies. CRPS is characterized by pain, changes in cutaneous sensitivity, autonomic dysfunction, trophic changes, and motor dysfunction. Untreated CRPS was characterized by 3 stages: acute, dystrophic, and atrophic. However, this sequential progression is hard to identify now that most patients are treated and do not display the later stages of the disease progression. So we don't rely on this classification anymore, acute, dystrophic, and atrophic. But it's one of these classics in literature, and you should know about it. Just the names, the 3 stages, okay? Spontaneous pain is present in most of the patients. It can be burning, sharp stabbing, electric-like shock, aching, and quality may vary in time. The pain appears disproportionate. Remember the 4 Ds. First D is disproportionate, okay? Disproportionate pain to the inciting event. All right, this is my classification. 4 Ds. I'm gonna show it to you at the end of the presentation. But remember, 4 Ds, disproportionate pain to the inciting event, dysautonomic, symptoms, and dystrophic signs, and diagnosis of exclusion. These are the 4 Ds of the clinical picture of, the CRPS. Autonomic dysfunction manifesting as edema, changes in sweating, hypo or hyperhidrosis, skin color changes, skin temperature differences. These signs can vary from time to time and may be reported despite not being obvious at the time of the examination. Trophic changes are largely the result of disuse, and they include changes in nail growth and aspect, skin changes, being thin or shiny or thick, hair loss or hypertrichosis. Bones are osteoporotic and joints may ankylose. The motor dysfunction includes weakness and later atrophy. Dystonia and tremor are also described. Remember dystonia, okay? You can add it to the list of these here, because it has a specific treatment in RSD. If you do a thermography, you will see, basically unequilibrium, vascular changes. Like here, for example, the temperature is increased on the right upper extremity here. And you can do something called, it's called cold challenge test. We used to do a lot of these when I was a fellow in the mid-90s here, thermography. With the cold challenge test, that the skin temperature doesn't return back to normal, in RSD patients after being exposed to a cold solution. Usually, like a bucket of ice, we put the non-affected limb in a bucket of ice, and this will, challenge the sympathetic nervous system. Stages of CRPS, as I said, acute, dystrophic, and atrophic changes. These are not really of, prime importance right now, but it's just one of these classics that you need to know about. Pain is the cardinal feature of CRPS, but there are also sensory changes, autonomic and trophic changes. This is basically the refined IASP revised classification and diagnostic criteria, and it's very similar to the Budapest criteria, but there's some, little modifications there. Again, I use my 4Ds and it works for me. And as you can see, the first item and the diagnosis here is continuing pain that's disproportionate to any inciting event. At least one symptom reported. I call this the dysautonomia symptoms. Hyperesthesia, allodynia. Allodynia is pain upon touch, okay? Vasomotor changes like temperature asymmetry, skin color changes, pseudomotor changes like edema, sweating changes, sweating asymmetry, motor such as decreased range of motion, motor dysfunction, or trophic changes. And then at least one sign at the time of the evaluation in at least two of the following categories. Sensory, vasomotor, pseudomotor, and motor or trophic. sensory like evidence of hyperesthesia to pinprick or allodynia to light touch, temperature sensation, deep somatic pressure of joint movement, evidence of temperature asymmetry, skin color changes, skin color asymmetry, evidence of edema, sweating changes, or sweating asymmetry, decreased range of motion, motor dysfunction, or traffic changes. And at last, no other diagnosis can better explain the signs and symptoms. Treatment. Progress has been slow in refining treatment of CRPS because the condition is complex and incompletely understood. The treatment has been varied and formulated to address presumed pathophysiologic causes and to ameliorate specific symptoms. The common goal is functional restoration. So, to make the story short, our goal in CRPS patients is to restore the function. Pharmacologic therapies, as well as regional anesthetics and surgical intervention, should be used in conjunction with physical therapy. CRPS prognosis in adults is more guarded than in children. In most children with recent onset CRPS will improve spontaneously and should be treated conservatively. And I had the chance to treat children, because I did pediatric anesthesia, and I worked at the pain clinic for a couple of months. And I can tell you, these guys, they improve with some amitriptyline and gabapentin and physical therapy and some psychological support. You don't have to do injections in these kids, except in extreme cases. CRPS pain management. I like to use an algorithmic approach. Step one is like CAM therapist, psychological therapist, physical therapist, pharmacological therapist. Step two is pain interventions, surgical interventions, such as surgical sympathectomy, dorsal column stimulation, and peripheral nerve stimulation. And you can add to step three also intrathecal pump, especially patients with dystonia. You can put an intrathecal baclofen pump. Physical therapy. As we said before, the main goal of the treatment in CRPS is functional restoration. Remember this word, okay? So physical therapy should be started as soon as possible as the diagnosis is made, even if it's a presumptive diagnosis. In cases in which PT has already been started after surgery, for example, the pain may worsen as CRPS develops, but discontinuing PT will only make matters worse. PT should continue, but the approach may be altered. The major role of PT seems to treat the secondary complications, such as decreased joint range of motion and subsequent atrophy. One randomized control study demonstrated that physical and to a lesser extent occupational therapies reduced pain and improved active mobility in recent onset CRPS1. Mobilization of the affected limb is of paramount importance. Elevation, massage, and contrast bath also have been used. Often the pain must be aggressively treated to accomplish this. This is called desensitization, and we're gonna show you a slide about desensitization. And this is one of the D's of the treatment. A gentle approach using heat, massage, vibration, and other mild stimuli will help to restore more normal sensory processing. Isometric strengthening should be followed by progressive stress loading as tolerated. One must be careful when using medication or in particular regional anesthesia in conjunction with physical therapy to avoid aggressive range of motion exercises and heavy loading to the affected limb. This desensitization for neuropathic pain. Because pain is so deeply wired in the brain as a danger signal, patients with pain often avoid touching or using painful areas. However, stimulation and use actually help some neuropathic pain conditions. We call it graded desensitization by stimulating the nerves just enough to be uncomfortable, resets painful nerves in some pain conditions. And of course, the CRPS is one of these pain conditions that we're talking about. So at the beginner, we'll start with massages, tapping, stretches, intermediate desensitization, rubbing, dipping, and advanced we do vibration and contrast bath. Another therapy for CRPS is mirror therapy, same one we use for phantom limb pain, because as we mentioned before, CRPS is peripheral and central at the same time, and the picture of the limb is dysregulated in the brain of the CRPS patient, and you need to resume this by doing this mirror therapy, very simple treatment done by a physical therapist. And then we get into pharmacological therapies, and there are different types of pharmacological therapies. But I want to mention that the ones that are supported by randomized controlled trials basically are bisphosphonates and oral steroids for short courses in the setting of the CRPS. There's also been emerging evidence for ketamine, memantine, epidural clonidine, intrathecal clonidine, baclofen, aerobic exercises, mirror therapy, and dorsal root ganglion stimulation. So you really have to be up to date with the emerging, therapies for CRPS. Evidence from randomized control trials suggests the efficacy of spinal cord stimulation for the management of CRPS and associated symptoms. Despite the important role for the sympathetic nervous system in the pathophysiology of CRPS, an update of Cochrane review found that there is inadequate evidence to support or refute the efficacy of local anesthetic sympathetic blocks. However, we describe medications proven effective for neuropathic pain, even if not specifically tested in multi-center randomized randomized trials in patients with CRPS. So we still use anti-neuropathic pain medications, despite we might not have robust evidence in the literature. So what are the pharmacologic therapies? Tricyclics, anticonvulsant, local anesthetics, NSAIDs, opioids, inhibitors of osteoclast activity, steroids, baclofen, phentolamine, clonidine, and ketamine. TCAs are very well-known anti-neuropathic medications. They inhibit the reuptake of the serotonin and norepinephrine in the brainstem. And this will basically send inhibitory pathways that will inhibit the pain at the level of the spinal cord. These are very nice adjuncts. They help sleep as well. Small doses of amitriptyline will be enough. uh, 10 to 25 milligram of amitriptyline will be more than adequate, in these situations. Anticonvulsants, our heterogeneous group of drugs known to treat neuropathic pain. The most famous of these are the gabapentinoids, and these are basically calcium channel blockers uh, working on the alpha 2 delta 1 subunits and type voltage gated calcium channels. Um, they have a nice profile. They're eliminated in the kidneys. They might induce somnolence, fatigue, dizziness, ataxia, and tremor. Sodium channel blockers. These are extremely important drugs here, the local anesthetics. They block the sodium channels, which makes the medication a useful anesthetic and antiarrhythmic. The sodium channel blockade is also beneficial for modulating neuropathic pain, which makes lidocaine is a useful analgesic. Lidocaine infusions is well tolerated and in most circumstances free of adverse effects. Generally speaking, lidocaine infusions are used to test whether the patient will benefit from a drug called mexilitine. Okay, we used to do this in old days. I mean, I don't think anyone is doing this anymore, but maybe so. I've done a lot of these. Uh, I want to say that mexilitine is a drug that's harsh on the stomach. Most patients don't like it. But anyway, I just wanted to mention it because it it has an importance in the understanding the mechanism of CRPS. Okay, recently transdermal lidocaine patches were used in sympathetic mediated pain in cases of patients that having post-herpetic neuralgia. Also, EMLA cream can be used. Nowadays, the compounding pharmacies in the United States, they compound local anesthetics with gabapentin, and they put sometimes doxapin, and they do a cocktail and ketamine. So there is no proof whether these topicals make a difference, maybe except in patients with CRPS and having, skin lesions. The topicals might be useful in treating this kind of lesions. Mexilitine is a sodium channel blocker similar to lidocaine, while it's in the oral form, and usually it will need a lidocaine challenge before you start the patient on. It has a narrow therapeutic index, and it irritates the stomach. So I've used this drug in the past. As I said, you know it's not used that frequently anymore. NSAIDs also are not used in CRPX except if there's an inflammatory component to the pain, like there's swelling, there's inflammation, signs of inflammation. You might use a short course of NSAIDs. Opioids is not our favorable drugs in neuropathic pain, uh, but sometimes you need it. And of course, I would prefer to use drugs that have NMD antagonist activity, such as methadone, for example. Inhibitors of osteoclast activity, these are basically calcitonin and bisphosphonates. And these drugs, for some reason, they been of a lot of interest to see, to physicians treating CRPS, especially the bisphosphonates. And they use pamidronate infusions, to treat CRPS. And it seems like it controls the pain in early CRPS by hindering the synthesis of prostaglandin E2, proteolytic enzymes, lactic acid, and pro-inflammatory cytokines. Calcitonin inhibits the synthesis of proteolytic enzymes and lactic acid. Calcitonin can be given either IM or nasally. Calcitonin and bisphosphonates. And we have different types of bisphosphonates. We have oral, we have IV form. I prefer the IV form in these situations. Bring the patient to your clinic and start an infusion of pamidronate for 4 hours. Corticosteroids, there's evidence behind them, especially in early cases. Adding some steroids will reduce the inflammation and help with the CRPS pain. Baclofen. Baclofen is useful in cases where the patient is, having dystonia, okay? And also baclofen is a GABA B is a GABA B agonist, and baclofen in fact can be used to boost the conventional spinal cord stimulators, okay, the traditional ones that depend on GABA in their action here. So when they start to fade, adding a drug like baclofen can help out and boost the spinal cord stimulation here. Also, it helps with spasticity. Sometimes, in CRPS patients, you have to place an intrathecal pump to run this baclofen. I mean, you can add also other agents to it, like local anesthetics like bupivacaine and clonidine and stuff like that. Okay. Phentolamine. Not a lot of folks know about phentolamine. It's an alpha blocker, and it's used an infusion test to see whether this patient is sympathetically mediated or sympathetically independent pain. They found that phentolamine, if given to CRPS patients, will block the pain, especially if it's sympathetically mediated pain. So it's like the lidocaine challenge test. Okay, if it works, you give mixilotine. Phentolamine, if it does work, then you can do these sympathetic blocks. In old days, we used to give alpha blockers orally, and right now this is nobody's doing this anymore. So very rarely I use it. Maybe for diagnostic purposes would be a good choice. Clonidine is an alpha-2 agonist working on the brain, inhibiting the release of norepinephrine and 5-hydroxytryptamine in the dorsal horn, inhibiting the pain by modulating the norepinephrine and 5-hydroxytryptamine release in the dorsal horn. Available in oral dosage, transdermal, and for epidural use. One of the side effects is sedation, xerostomia, constipation, orthostatic hypotension, and bradycardia. Abrupt withdrawal may lead to rebound hypertension. Tricyclics reduce effectiveness. Okay. Clonidine, an alpha-2 agonist. You can use it as an intravenous regional block, 1 mic per kilo. You can also use transdermal clonidine in certain areas, localized areas of hyperalgesia. I used to put clonidine uh, in epidurals, with patients having CRPS. I used to put it in the block itself. When I do, like, let's just say I do a peripheral nerve block, I add clonidine to it. And you can do it in intravenous regional block as well. Ketamine is a PCP derivative that produces dissociative anesthesia. It inhibits the NMDA, and basically it might cause sympathetic system stimulation, salivary and tracheobronchial secretions, and can cause emergence delirium. Reported efficacy is between 50 and 100% in pain control, but it's also depending on the other endpoint measures of efficacy and duration of patient post-treatment follow-up. Unfortunately, the ketamine, there's a high variability in the published protocols for ketamine infusions regarding dosing, duration, frequency, and timing of the ketamine infusions. More commonly, one low-dose ketamine infusion, 1 to 4 hours, administered, followed by longer infusion at higher doses in the next few weeks if there was some degree of improvement. Many patients will require periodic infusions, but some will not require additional treatments. Other options include inpatients 4 to 5 day infusions or outpatients 5 to 10 daily infusions. I mean, the protocols for ketamine basically are, just the ones that published are enormous, guys. Do whatever you're comfortable with. I do myself, and once a week, ketamine infusion. I start with small dose, and I go up on the dosage to up to 100 milligram once a week, and I add lidocaine to it. This is how I utilize it. But this doesn't mean anything. You can always follow one of these published protocols. But I want to say something here. First, when you do this ketamine infusion, first, the patient has to be MPO. Second, you have to warn the patients about the side effects, especially the, some of the, dissociative, signs and symptoms that happen with ketamine. And also you have to have, somebody that drives the patient home after the ketamine infusion. They cannot go home, they cannot drive after getting a ketamine infusion. Also, I give midazolam, while the patient getting ketamine to reduce some of these psychomimetic effects. Some of these psychomimetic effects will be very distressful to some patients, guys. So be careful about it, All right, we have something I would say rather recent here, and probably has a lot of potential. Low dose naltrexone. All of you guys know what is naltrexone. Naltrexone is used in opioid addiction and alcohol addiction. The usual dose is 50 milligram, 50. But they found that if you give a very tiny dose of naltrexone, 1.5 to 4.5 milligram, we call it LDN, or low dose naltrexone, it does help the pain quite a bit by reducing the central sensitization in the brain. And it has a lot of applications in pain syndromes that are cortical in nature, such as, for example, fibromyalgia, also complex regional pain syndrome, and other problems that are central in origin here. Um, Look it up, and this is pretty safe. The most important thing that you have to, taper the patient off completely any type of opioids, because this actually blocks the opioids. So when you use it, it blocks only the endogenous opioids. That's what we're looking for, and this really basically reduces the central sensitization process here and helps with the CRPS. Pain interventions. Pain intervention varies from trigger point injections up to spinal cord stimulation, peripheral nerve stimulation. And as we said, in selected cases, you can do also intrathecal pump for baclofen in patients with dystonia. Acupuncture. I done acupuncture for a patient with CRPS. It's very nice. Acupuncture, just to wrap it up in few words here, I use the contemporary acupuncture. I call it the biomedical acupuncture. It's a hybrid of different techniques, basically depending on selecting three types of points, acupoints. The paravertebral points, these are like the ones 2-3 centimeters from midline, and number two, the homeostatic points, which are the points that generally induces generalized effects when you stimulate them, and the first ones to appear after an injury. And then you have the symptomatic points, which are the points at the site of the lesion. So in CRPS, we're going to use only two sets of points, okay? We're going to use the paravertebral points, all right? And we're going to use the homeostatic points. We're not going to use the symptomatic points because these points are already injured. So, and this works very well. I mean, for me, I've done a lot of these cases. Unfortunately, acupuncture needs commitment. You need to come once a week or twice a week. That's the biggest challenge with acupuncture. But the results are pretty good and fascinating. Also, one of the under treated areas in CRPS is myofascial pain syndrome. Now, I want to say that CRPS is a neuropathic pain, but in fact, it's actually there is a nociceptive element and an inflammatory elements as well. So, for example, myofascial pain is very predominant in CRPS, not in the area, maybe in the muscles around it. It doesn't. If it doesn't get treated, the patient is usually hurting, and if you do just very few trigger points, not in the area of the lesion itself, of course, the other muscles in the body that's affected, the secondary, secondary to the initial lesion. And it could be a problem, for example, lower extremity, a patient having trigger points in the back, for example. Then you do trigger points in the back. All right, sympatholysis. These are sympathetic blocks that we use to determine whether the patient is sympathetic mediated or sympathetic independent. The most famous of them are the stellate ganglion block and also the lumbar sympathetic block. Now, the problem with the stellate ganglion block, it can skip a nerve called the nerve of Kuhn's. So in this situation, you have to do thoracic sympathetic block, okay? And unfortunately, the thoracic sympathetic blocks are associated with high incidence of pneumothorax, like up to 6%. So not a lot of physicians kind of prefer doing these blocks. But if you're good at them, I mean, it's better than doing a stellate ganglion block. And you can do a radio frequency if it helps the patient. The initial block helps the patient. As you see here, a patient after a stellate ganglion block had Horner syndrome, okay? Ptosis, meiosis, anhidrosis, and nasal stuffness. I mean, you guys are, the classics of Horner syndrome. This is done under X-ray. You can do it under ultrasound. Lumbar sympathetic neurolysis is used for lower extremity. And if it does work, you can do a radiofrequency ablation, or you can use a neurolytic agent. Unfortunately, with the lumbar sympathetic neurolysis, if you're using, one of these neuroablative procedures, you can result in something called genitofemoral neuralgia. And this is a very common question in the board exam, okay? Especially if you're at L4. Sympathetic neurolysis could be done chemically using phenol, or you can do it also, using percutaneous radiofrequency, conventional radiofrequency. Intravenous regional blocks. And while I'm doing my fellowship in the mid-90s, we did a lot of these intravenous regional blocks with beryllium and mixed with lidocaine and other agents. I mean, the only problem in my mind, with the intravenous regional blocks, sometimes these patients really, their arm is very sensitive, or their lower extremity is very sensitive, and trying to wrap it up and putting a cuff could be very painful. Okay, so and sometimes it works very well. It depends from one patient to another, but definitely you have to give sedation before you do these blocks. Their role right now is diminishing, not like old days. I mean, we used to do this intravenous regional block right and left. Right now, most of us do the block itself, like the stellate or slash thoracic sympathetic blocks, or intravenous or lumbar sympathetic block, in favor to intravenous regional blocks. Also, in UK, they used an agent called guanethidine, but this one was never approved in the United States. I'm not sure, maybe right now it's approved. So we used to use beryllium. Of course, we had to mix it with lidocaine, 0.5%. Epidural blocks. So again, I want to get back to my old fellowship here in the mid-90s at Rush. Basically, we used to do epidural blocks, and we used to admit the patient for 5 days, whether it's a lumbar or cervical epidural, and do physical therapy during this 5 days admission. And then sometimes we, even tunnel a catheter and send the patient home with an epidural infusion for 6 weeks. All of these are, good methods to treat CRPS. But the problem is, in my mind, is that it's manpower, and needs a lot of personnel here. Somebody to deal with the infusion, nurse to take care of the patient at home, change the bag, these kind of things, it's labor intensive in my mind. Okay. Uh, and also, if you're going to admit the patient for 5 days, also, it's very expensive, to do that. This is a lumbar epidural. Of course, we do all of these under C-arm guidance, guys, okay? Because you need to be very precise when you do these epidurals. You want to be at the segment that's causing the pain, okay? It's preferable to go even to the side, thread the catheter at the side of the problem, whether it's right or left. Cervical, we've done it for for upper extremity RSDs as well. Okay, brachial plexus block, and also I used to do popliteal blocks, are also very nice adjuncts for CRPS. And you can add clonidine to it. This will help, or sometimes they add steroids, dexamethasone. And you can place a catheter, brachial plexus catheter, like supraclavicular, for example, infraclavicular. Actually, infraclavicular is a better choice. Brachial plexus block, we have different blocks: interscalene, supraclavicular, infraclavicular, and axillary. Interscalene will be useful for RSD affecting the shoulder. Popliteal block for foot RSD or causalgia. You can do it under ultrasound. Sometimes I used to do these peripheral nerve blocks plus doing the ketamine infusion in the same setting. Okay, nowadays there's so much interest in dorsal column stimulation, and there's an interest to start it early on, then preferably then later on during the course of the disease. And you can do it either for the lower extremity or the upper extremity. For the upper extremity, you thread the lead to C5, 7 levels. And as far as the lower extremity, to T8, T10 levels. It seems critical to have a good overlap between the induced paresthesias and the painful areas. Approximately 50% of the pre-selected patients with CRPS will have a positive response to stimulation during the period of trial. Approximately 70% of these patients will have a good to excellent long-term benefit. A goal of pain relief is reasonable in view of refractory nature of the pain and patients selected for this expensive therapy. Although if treatment is started early, one could hope functional restoration may be achieved. Literature suggesting utility of earlier use of spinal cord stimulation in patients with CRPS, although an exact recommendation on timing has yet to be determined. Spinal cord stimulation waveform technology, I summarize it into 5 statements. We're going to have hopefully a presentation on spinal cord stimulation, dorsal column stimulation, and peripheral nerve stimulation in the future. But just, in short, you need to know 5 things about any spinal cord stimulation: current versus voltage. Is it tonic stimulation? Is it high frequency stimulation? Is it burst stimulation? or is it high density stimulation? To make the story short, tonic stimulation is basically the traditional, conventional, dorsal column stimulation, and this, as we said, is GABA mediated. GABA is the mediator, gamma aminobutyric acid mediated. Okay, and this is the one that causes paresthesias when you place it. And unfortunately, a lot of patients do not like these paresthesias. So they came out with other types of stimulation, like high frequency and burst stimulation, that don't cause, paresthesias. Um, Burst stimulation is the nearest one to our human body, okay? And it's not GABA mediated. High density stimulation is basically like you're giving a loading dose, with for a drug, for example. Okay, a current versus voltage. Whether you use the current or the voltage, uh, you know, uh, to monitor the spinal cord wave form here. Um, they say that the current is less painful, more comfortable to patients. I mean, not more than that. We're gonna give a talk about dorsal column stimulation, and also we have something called dorsal root ganglion stimulation, and this is basically the state of art dorsal column stimulation right now. And in DRG stimulation, it's directed targeting. The accuracy of this treatment has proven to be effective in 94.5% of patients. And you're using low energy. DRG stimulators use a tiny amount of energy, only about 10% of the energy that's required from a conventional spinal cord stimulator. Low risk of lead migration. One of the biggest challenges in dorsal column stimulation is the lead migration. This one has less than 1% migration rate versus 14% for dorsal column stimulators, and minimal effects on body position. So if you change your posture, this will not change, the location of your lead. DRG stimulation. The lead is placed at the dorsal root ganglion of the area affected. Peripheral nerve stimulation is also the state of art in this technology here of dorsal column stimulation and DRG stimulation. Peripheral nerve stimulation is much more safer. And remember, we talked about peripheral nerve blocks versus central blocks. The more you go peripheral, the less side effects and complications. Probably less quality of analgesia. But these are pretty safe, you know, uh, gadgets where you place the lead along the nerve, especially in CRPS type 2, because you have a localized nerve lesion. Remember, CRPS 1 is RSD, CRPS 2 causalgia, which is related to a nerve injury, specific nerve injury. So these peripheral nerve stimulation is really a very good choice for CRPS type 2. And this is how it looks like. This is the implanted lead. You have an external transmitter and you have a patient programmer. Psychotherapy is also important in patients with CRPS because they develop anxiety and depression. Um, I put all the modalities here and the basic mechanism of action. This slide got it all here. So take a note of it. You can stop the slideshow and look at this picture here. Okay, I developed some sort of an algorithm for CRPS. Step one, two, and three. Step one is basically conservative measures. Step two are basically the sympathetic peripheral nerve injections. And step three is the surgical techniques, including dorsal column stimulation, peripheral nerve stimulation, and even intrathecal pumps and sympathectomies, surgical sympathectomy. So these are the conservative measures. The most important is the physical therapy, of course, and the drug therapy. Um, CRPS type 1, conservative, you need to identify whether sympathetically mediated or sympathetic independent. If it's sympathetically mediated, you can try sympatholytic injections and neurolytic, sympathetic neurolytic blocks later on if they work. If it's sympathetically independent, you can try peripheral nerve injections. Okay. And then at the end, you might do a dorsal column stimulation, DRG. If it's a CRPS type 2, you do a peripheral nerve stimulation and a baclofen pump for a patient with dystonia. Mnemonics. Okay, these are mnemonics I developed for CRPS. 4Ds for the clinical picture: disproportionate pain, dysautonomia symptoms, dystrophic signs, diagnosis of exclusion, treatment desensitization. This is the physical therapy modality that we talked about. Drug therapy, diagnostic blocks, dorsal column stimulation. Key learning points. Most CRPS patients are best managed with a combination of a skilled physical therapist with medication and intervention of pain modalities. The aim is always to start treatment early to optimize function. Okay? Again, remember the goal of therapy in CRPS is functional restoration. And I want to say something for the record here. CRPS, I mean, you can look up the diagnostic criteria, guys, but sometimes when you really think about it early on, you can pick up early cases. And when you do so and treat it aggressively from the get go, you can actually eliminate the disease. And this happened with me. I mean, I have to be thankful because I got trained in a place was like a RSD, a referral center. So I've seen a lot of these patients. So I had this, experience to pick up these patients early on and treat them. And this, made a huge change in the outcome of these folks. So, unfortunately, CRPS it's not a common disease or syndrome, and in fact, it gets missed, and the patient gets into this chronic debilitating phase until he starts to get the actual treatment. So I just want you to I want to have some sort of always think about CRPS in your mind. When you see these pain syndromes, because if you pick it up early, you will definitely make a change to the patient. Thank you so much.